Yeah. So we're going to be talking about ARDS mimics today. It's it's a difficult to talk about topic because it's difficult to define. That is the first thing. So I'll just get on straight ahead. If you have any questions or you want to talk about something in more detail, feel free to do that anytime. This is more like an overview because every ARDS mimic is its own discussion. So we'll just try and see, what you can do when a patient comes to you who has something looking like an ARDS, right? So this is how we're going to be talking about. We're just going to briefly talk about what ARDS is, what ARDS mimics are, and then we'll just talk about 4 or 5 ARDS mimics very, very briefly, just to see, because these are quite characteristic, the individual ones that we're talking about, and there's something important that you'll have to either tease out or you'll have to, diagnose. So that's why we're going to be talking about these things. So first, let's come to ARDS. What is ARDS, right? So ARDS is a clinical syndrome of acute hypoxic respiratory failure due to lung inflammation, not caused by cardiogenic pulmonary edema. So, this is just the broad, how do you say, a definition that you can say. But let's go on to go on a little bit further and we'll get into the nitty-gritties just in some time. So just some facts. ARDS constitute 10% of ICU admissions, and they constitute about 1/4 of the patients who are mechanically ventilated in the ICU. And they have a very high hospital mortality, almost 40%. All of this has been taken from one single study. So definitely the data would vary between centers and the causes of ARDS that are there. So, but if you just look at this, then you can see that, okay, you're going to be dealing with ARDS quite a lot, especially if you're in a medical ICU or in a mixed ICU setting also. Now, this is the ARDS definition, the global ARDS definition that came out in 2023. So just above this table, they have something called as their conceptual model, which we'll come to a little later. But this is the general definition. So all ARDS must fit the first 3 criteria. This is kind of similar to the Berlin's criteria. You need to have a predisposing factor, and the illness that is caused should not be because of pulmonary edema and should not exclusively be attributed to fluid overload or something like that. The timing is very important. You should have either new or worsening respiratory symptoms within 1 week of onset of illness. And then chest imaging is important. Chest imaging, you have bilateral opacities, which can either be done on chest radiography or a CT scan, or now the new definition also includes an ultrasound scan if it has been done by a well-trained technician or a well-trained professional. But there should be, it should not be completely explained by effusions, atelectasis, nodules, or masses. Okay. So what is new here is this ultrasound thing that has been applied to the all ARDS category. One thing you should note is that even if there is some pulmonary edema or fluid overload, if you're not able to completely explain the patient's condition because of that, you can say that ARDS is present, even if even if you have pulmonary edema, but that is not very significant. Okay. Now let's come to the criteria that are applied to specific ARDS criteria. Now they've introduced like non-intubated ARDS and modified definitions for resource-limited settings, and we'll just talk a little bit more about this. So the intubated ARDS definition is similar, like mild, moderate, severe have the same PF ratios of 200 to 300, 100 to 200, and less than 100. What is new is the SF ratio, which uses a saturation if the saturation is less than 97%. This is excellent because it is kind of non-invasive, but it is also not excellent in the sense that, how reliable is SpO2 in many of the patients, especially if these patients are in shock or something like that. So that is something you'll have to think about. Then you have non-intubated ARDS patients. In non-intubated ARDS patients, they have now included HFNC with a flow rate of more than 30 liters per minute, or NIV or CPAP with at least 5 centimeters of water and expiratory pressure. And again, you have a PF ratio and SF ratio to define ARDS. Now, again, what is important here is that, this kind of removes the standardization of ARDS, especially in intubated ARDS. You're measuring all these PF ratios with a PEEP of 5. So when you bring in HFNC or NIV or CPAP, you're kind of making that a little, how do you say, not rigid. Because HFNC at 30 liters per minute flow can create a peep of anywhere between 2 to 7 centimeters of water, and it is subject to leak and those kind of things. Similarly, even NIV can be subjected to leak, and you're not really sure about how much PEEP you're giving. So it has been noted that in many patients, the PF ratio, especially, or the oxygenation, rapidly improves once they're intubated, and you have a more controlled kind of ventilation. So it is important to remember this non-intubated ARDS, and even more so important to remember modified definitions in resource limited settings, where they say you don't need PEEP at all, and you just need a minimum flow of oxygen. You don't even need an oxygen flow rate to define it, especially in the resource limited settings. So what they have done is, they've introduced more uncertainty into the definition. And resource limited settings, they say that, these are the places where you don't have blood gases, and, you don't have access to all these fancy things. So that is where you're going to apply this. So we'll see why that is a problem. So if we go on to, like I said, the conceptual model. The conceptual model was placed above the definition, and this is the very first line. Okay, it is like a one paragraph thing, but it says ARDS is an acute, diffuse inflammatory lung injury precipitated by a predisposing factor. This is all that I want you to kind of remember. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Sujay, your voice is echoing.
Oh, okay. Just give me a minute. Is this better?
Yes, Sujay.
Yeah, okay. So this is all that I kind of wanted to remember, this first sentence, and we'll come to it, as to why this is important. So remember these words: acute, diffuse, inflammatory lung injury precipitated by a predisposing factor. So let's look at the common factors or the risk factors that, precipitate ARDS. And these, the most are direct lung injuries or indirect lung injuries. The most common ones being pneumonia, aspiration, and non-pulmonary sepsis. Apart from this, you have a lot of other ARDS risk factors also, like, pulmonary contusion, inhalation injury, near drowning, drug overdose, pancreatitis, and so on. Just keep this risk factor list in mind. It's not important to remember right now, but we'll come to it why it becomes important during ARDS mimics. So how do we manage ARDS? This is how we do a lung protective ventilation, proning. We use a high PEEP strategy, and we use corticosystemic corticosteroids as well. So we can use VV ECMO. I'm sorry for the car noise in the background. So we can use neuromuscular blockade and VV ECMO as well. Now, so what is the point? Why do we have to look at ARDS mimics, right? So we have a definition, we have bilateral infiltrates, we have like a PF ratio. So many people come with this, just manage with the ventilator, just manage with steroids, it is done. So that's not really how it is. So what exactly are ARDS mimics? So ARDS is the final common pathway. Like we said, you have a lot of, either the lung gets injured or the body gets injured, and something systemic, some inflammation happens, and this leads to ARDS, and it's like a final common pathway. So what is important is many conditions can lead to an acute presentation, like we'll see, with bilateral infiltrates and hypoxia, and these need not be ARDS itself. So ARDS, when something is, so how I like to think about it, I don't know whether I'm right or wrong, and I've had a lot of discussion about this. So my thing is, you have some inciting factor like sepsis or aspiration or something like that. Then you develop this worsening respiratory failure, which is bilateral symmetric because of something systemic happening, and that is ARDS. But there are a lot of diseases which can have similar presentations, like even bilateral pneumonia without ARDS can mimic the same thing. They'll have low PF ratios and so on. So it is very difficult to differentiate ARDS from ARDS mimics. So the most important thing to do as clinicians is to not reflexively label any severe bilateral pulmonary disease as ARDS. That is one of the worst things that can happen to a patient, because, we'll talk about the, benefits of, not doing this. And the other important thing is there's no standard definition of ARDS mimics, right? So I'll talk about this no standard definition when we look at some examples of ARDS mimics. So when do we suspect it? So we saw that the ARDS Berlin definition has a time frame of 1 week. We have, like I said, risk factors are there, bilateral disease and infiltrates or whatever. So the important thing is, when the timing doesn't fit, the patient comes to you, they say 1 week of history, but then, you go on to the course of the patient and you see that it's not really 1 week. Some family members say, okay, he might have been sick for 2 weeks, maybe 3 weeks. So when the timing really does not fit, or when the patient actually says that, okay, or the attendants, I guess, say that, they have been sick for a little longer, it is very important to rule out a chronic process or chronic process that can lead to an acute exacerbation during, in such a history. The other important thing is absence of risk factors. Like I said, the conceptual risk factor said that it is because of a predisposing risk factor. And we showed the table of the risk factors also. So if you're not able to, very clearly say that, okay, this was the inciting factor and this is why the ARDS happened, you're not able to find the risk factors, that is one of the most triggering thing for you to investigate further in a patient who comes with an ARDS like picture. Another important thing is beware of diagnostic creep. So what does diagnostic creep mean? Like we said, the ARDS thing itself is like an umbrella term, right? So all you need is some bilateral infiltrates, that to an X-ray, which is not really, able to show you good details of what is there in the lung. Then you have, in resource limited settings, you've removed the flow basics, you've removed the PEEP characteristics. Now you introduce non-intubated ARDS also. So now it has actually become more and more easy for people who are not aware to club important diagnoses into ARDS and treat them, with just mechanical ventilation, when some diseases that are mimicking ARDS will have specific therapy and better outcomes than ARDS itself. So, you should be very aware that the diagnostic criteria is great, but it also has a lot of loopholes and you have to be aware of that. So let's look at why it matters. Why does it matter? So we've been talking about ARDS mimics. Okay. So a retrospective study was done on 665 ARDS patients requiring invasive mechanical ventilation, and then this study grouped, the patients based on common risk factors. Now the common risk factors were similar to the ones that the table that I showed you, but not exactly. But more or less you can compare them. They found that about 7.5% of patients out of 665 do not have common risk factors, right? Then they looked at the mortality. This was just a trend, but they could find that the ICU mortality was lower in patients without these risk factors than with these risk factors. And by the end of it, there was a higher steroid use in those patients without these common risk factors. What it means is that patients who don't have these common risk factors, they might do better because you are kind of picking up a specific diagnosis and treating them properly. And if you look at this number, this is about how it is going to be. If you have 100 ARDS patients, maybe 8 to 10 of these patients might have ARDS mimics. And that is also important to know that, it's not going to be like 50, 60% or so if you actually investigate the ARDS properly. Let's look at another study that was published in 2018. This was also a retrospective study of about 50 patients of ARDS, and all of these patients underwent the open lung biopsy. This, whoever had an open lung biopsy, they included them. They found that about 60% of the patients did not have diffuse alveolar damage. Now, diffuse alveolar damage is like characteristic histology for ARDS, right? So they found that at least 60% had an alternative diagnosis, and these included some things like CTD or interstitial pneumonia, PCP pneumonia, organizing pneumonia, all of which are treatable. And out of this, you have 37% of patients who had steroid sensitive pathology. Okay. Now, if you look at the steroid sensitive group, they had really low hospital mortality or in-hospital mortality, and and once they did an open lung biopsy, they actually had a therapeutic change in their management. So this is why identifying ARDS mimics becomes important. Let's look at some examples of ARDS mimics. So it's going to be a very exhaustive list. Like, you have diffuse DAH, acute eosinophilic pneumonia, acute interstitial pneumonia, pulmonary vasculitis, acute exacerbation of ILD, drug-induced lung injury, cryptogenic organizing pneumonia, and disseminated malignancy. So these are just some examples of ARDS mimics. Okay, but there are going to be a lot more. You can have things like radiation pneumonitis, vaping induced lung injury. All of these are ARDS, but plus minus, you can call them mimics also. Like I said, the definition of mimic is not very well defined. So anything that is not, like I said, risk factor plus systemic inflammation leading to ARDS, you can probably call as a mimic, right? So why this becomes important is, if you look at these, all of them except for the disseminated malignancy are going to be steroid responsive. All of them are going to have steroids, right? Even though they come as ARDS, you're going to ventilate them with low tidal volume. You have to give these people steroids and they'll do well. Now, we saw in the previous ARDS management protocol that steroids are included, and that is the same dexa 10 mg or something like that. But these diseases, we're not talking about dexa 10 mg or like a 1 mg per kg steroids. When these patients present with such profound respiratory failure, you're looking at grams of steroids. You're looking at pulse steroids, which is going to save their life, without which they're not going to do pretty badly. So what you're looking for when you're looking for ARDS mimics is very simple. You're looking for a disease that can be steroid responsive, or maybe you're looking for a malignancy, right? That is, as simple as I can put it, even though that may be wrong way to put it, but it's understandable. So how do we diagnose? So one important thing, so some history points become very, very important. One is a medication exposure, like, any and every drug can cause probably some or the other pulmonary manifestation, and we'll come to how to identify that later in drug-induced ILD. History of vaping is important because you're going to ask patients about smoking and BD cigarettes and those kind of things. But when you ask a patient about smoking, they're not going to come out to you with a history of vaping, right? So people think that, okay, fine, I'm not smoking, but vaping is completely different, though it's actually not. So especially in a younger population, specifically ask for a history of vaping and a temporal correlation. And some of these patients, if they are chronic, if they keep vaping on and on, they'll have these recurrent symptoms where they keep getting admitted with respiratory failure to the hospital. Need not be like very severe intubation types, may require just low flow, but it is important to know. Malignancy itself can present as an ARDS mimic, like we'll see one image about how it looks. But apart from that, malignancy itself can, the drugs, the chemotherapy that is used to treat, immune checkpoint inhibitors, radiotherapy, opportunistic infections that happen due to the immunosuppression, all of these can present as ARDS mimics or some sort of pneumonitis that can happen. Blood product transfusion is important because they can lead to a transfusion-related lung injury. And rheumatologic prodromes are especially important, like joint pains or rashes or anything like that, urinary symptoms. Problems happen in adults who don't live with the attendants, and in that case, clinical examination becomes very important. Complete head-to-toe examination for a rheumatologic prodrome or, any sort of drugs, it is very, very important, right? This would be an ideal diagnostic pathway for any patient who comes in with ARDS. So basically, we look at, are they fitting into the ARDS criteria? Then we look at whether there's a clear precipitant. Like I said, risk factor, yes, no, right? If there is no risk factor, this is what we're looking for. And if you feel that there is no heart failure, you rule out heart failure based on an echo and, proper past history and maybe, BNP and so on. If there is no feature suggestive of heart failure, then you have to do an extensive evaluation, can include bronchoscopy as well to identify an etiology. If you identify an etiology, excellent, you treat for it. If you don't, then you can also consider lung biopsy. Okay. So earlier I showed you a study where they had done open lung biopsy, and we found that 50 patients had undergone open lung biopsy. That was over a period of 10 years, right? So that is how rarely you're going to be actually performing lung biopsies. It is not common. It is actually quite rare, even though it can be diagnostic. That is because on a mechanically ventilated patient, doing a lung biopsy can lead to quite a few complications. So what investigations are we going to do? The most important is, so you look at it in three terms, right? Infection, inflammation, and malignancy. So infection would be a precipitant for ARDS itself, need not just be in the lung. So you do a CBC and then you do a complete infective workup, can include blood cultures, respiratory viral panel. You can send things like BioFire. If not from the respiratory, if not from the nasopharynx, minibal also. Urinary antigens for pneumococcal Legionella, viral markers for HIV, and a beta D glucan if you're suspecting a PCP, and procalcitonin if you're suspecting bacterial sepsis. You should also ideally look at the abdomen and look at the urine for alternate sources of sepsis, right? Then if they're not really fitting the timeline, if they have something you think you're suggesting an alternate cause, or if you think that you can't identify risk factors, then do a complete autoimmune workup, right? ANA, rheumatoid factor, anti-CCP, ENA panel, myositis panel, anti-GBM, ANCA. These are all very, very important. So you have ANCA-associated ILD, you have a CTD ILDs with flares. All of these can mimic ARDS, and we'll come to this in brief a little later. Then the important thing is radiology may not always be helpful. So we looked at a lot of diseases like, cryptogenic organizing pneumonia, drug-induced ILD, and so on. But the thing is, when you're looking at ARDS mimics, it usually means that you have a CT scan and you think that, okay, this is definitely ARDS, bilateral consolidation, bilateral, ground glass opacities, and so on, with no specific features like, no pleural effusion, no nodules, no cavities, or things like that. So we are really looking at those subset of people where the radiology is also not very helpful. One thing that is very helpful is a bronchoscopy and BAL, or a bronchoscopic brushing, right? So most times what we feel is, okay, the patient is on NIV, HFNC, it is very difficult, we should not do it. But by not doing it, sometimes you kind of you're stopping the patient from getting some good therapy that might actually save his life. So if you are in doubt, especially if it's like a young patient and you're not able to find a cause for ARDS, you should always do a bronchoscopy and BAL. For one, you have to send a complete infective workup. Say you have a patient with how do you say, post lung transplant, post bone marrow transplant, some immunosuppression. The complete infective workup not only includes your bacteria, viruses, PCP, you can, common viruses, you also include things like measles, CMV, varicella, those kind of things into the infective workup. This is what a complete infective workup means. Cell counts and differentials are very important, especially when you're looking at diseases like acute eosinophilic pneumonia, where the BAL is going to have a lot of eosinophils, and that can clinch the diagnosis. Malignant cells can also be picked up, especially if it's a pneumonic type of lung cancer, on just the BAL cytology itself. Now, important to note is that, okay, fine, you may not have access to a bronchoscope, especially in a patient who is intubated. Sending good minibal samples, maybe 1, 2, 3, 4 times, how many ever times you can, sending it will actually help and get the diagnosis. We've gotten a lot of minibal eosinophils positive also, which has been very helpful for us in diagnosing. And like I said, lung biopsy can be done as a last Hail Mary in patients who have non-improving ARDS. Like I said, this is going to be quite rare, right? So we'll start off with the individual mimics. We're going to be talking about, no, wait. So once the meeting ends, you can probably go ahead to the next link. We'll just be talking about maybe 4 or 5 mimics in just brief, right? But before this, I just want to say that any patient who comes to you with ARDS will anyway be getting antibiotics. They're going to be getting some amount of steroid, even though they'll be low dose, and lung protective ventilation. All of these mimics will present like ARDS, so you will be giving them lung protective ventilation. What you're trying to do is try and find a treatable cause, right? So the first thing we're going to be talking about is diffuse alveolar hemorrhage. So diffuse alveolar hemorrhage is basically when you're having bleeding into the alveolar spaces, and this is originating from the pulmonary capillaries, right? It can happen if the pulmonary capillaries kind of get inflamed, or sometimes if you have like a bland hemorrhage with no inflammation, or even in cases of diffuse alveolar damage, you can have these. Most importantly, about 30 to 40% of them are due to connective tissue disease, of which majority are ANCA-associated vasculitis, right? Either GPA, EGPA, MPA, something of the sort. And 20% of them can be by lupus and anti-GBM syndrome. Okay. So we'll come to what investigations you're supposed to do when you suspect DH. How do you suspect DH? Like I said, we'll come to that. So causes. The first mechanism that we saw was pulmonary capillaritis. And when you have capillaritis, you have a myriad of causes. One would be, like I said, vasculitis, including IgA nephropathy, CTDs, any sort of CTD, SLE, rheumatoid arthritis, systemic sclerosis, MCTD, all of them can present with capillaritis and DH. Drugs like carbimazole and differentiation syndrome when you give ATRA, or others like, infections like leptospirosis and infective endocarditis. I think Praveen sir is the master of leptospirosis. He'll know more about this. So that is where the pulmonary capillaries get inflamed, and that is when you're getting like DH. And you have other causes like bland pulmonary hemorrhage. So this is when you have basically patients with CLD or patients with leukemia, patients with ITP, TTP, HUS who have thrombocytopenia, or patients who are on anticoagulation, antiplatelets. They come to you suddenly with, bilateral respiratory failure with bilateral infiltrates. It is very important to bronch these patients and kind of identify whether they're bleeding or not. Coagulation parameters like APTT, PT are also very important because, all of these, so you're going to have CLD with an INR of 10 or something. They have frank coagulopathy. And, some people think, okay, this is capillaritis DH and start giving them steroids. No, bland pulmonary hemorrhage is all about just, correcting this coagulation parameters and treating them. Then you have diffuse alveolar damage. Any ARDS or drugs that cause ARDS like amiodarone, nitrofurantoin, radiation pneumonitis, pulmonary infarction, all of these can also, when you bronch them, can have some amount of hemorrhage, although the blood return may not be as much as in capillaritis or bland hemorrhage, right? So one mimic is DAH, but the cause of DAH itself is like so many. It is very important to identify. So when you when you are thinking of DH, one is to confirm the diagnosis and then to search for an etiology. So patient comes to you with ARDS. When are you actually thinking of DAH, right? So one will be clinical. Clinical is patient has hemoptysis, patient has a drop in hemoglobin. Those are very good clinical features pointing towards DH. But important to know that not all DH patients will have hemoptysis. They can present with just a hypoxic respiratory failure, right? And they can present just like ARDS. People say that, okay, radiologically you can have some subpleural sparing, but again, radiology is not going to help you, many of the times. What is going to confirm is you have to bronch the patient, do a BAL, and you keep putting in aliquots. Aliquots are basically like, 60 ml or something ml of fluid into the alveoli and keep taking in returns sequentially. And you see that as more and more aliquots come out, this becomes more and more bloody. That is because initially you're getting out the fluid from the proximal airways, and as you go to the later aliquots, you're going to have them coming from the alveoli. So that is why that is how DH is actually diagnosed. And some cytology can show you hemosiderin-laden macrophages when your pathologist is actually excellent. So once you have DH confirmed, it is important to look for an etiology. Once you have DH, very important, look at the urine routine, urine active sediments, renal function testing, very, very important. And apart from that, this is just a trigger to send an ANA, ANCA, MPOPR3 and anti-GBM antibodies, right? So once you have this panel, you can start treating the patient before the results even come in if you think that it is because of capillaritis and not bland hemorrhage. So how you treat it, like I said, low dose steroid not going to do anything. You're going to have like IV MPS pulse therapy for 5 days followed by tapering steroids. You can up it with immunosuppression with cyclophosphamide or rituximab and plasma exchange, especially in renal dysfunction. So in this talk, we're not really going to talk too much about the treatment because, like I said, most treatment is going to be pulse steroids or steroids of some sort. It is important to kind of look at the clinical features and how to identify these patients. That is where we're going to be focusing on, right? So now that we've covered DAH, let's look at acute eosinophilic pneumonia. Sir, should we just go on to the next link? It'll be easier. I mean, we can have like a continuation then.
Yeah, sir. Yeah, Sujay. We'll join in the next.
Okay, yeah. So we can join the next link.